Hello and welcome to the second issue, the second coming of the Mental Health Avengers. This is Age of Access. I am Anthony Sitko from Capes on the Couch, and I am joined by my co-host of Capes on the Couch, the first time joining us in this series, Dr. Issues.
Hi, is everyone there? Yeah, I'm Dr. Issues. I am a board-certified psychiatrist. I have been doing this for a long time, and for whatever reason, they keep kicking me up into these progressive levels of our system because I'm supposed to be doing good for people, I guess.
You're doing very good for people. Don't let him tell you otherwise. And so then we've got Guardians MH joining us. You guys introduce yourselves.
I'm Dr. Goku. I'm a resident in psychology in a small little town in Canada.
And I am Joe. I'm one of the team members over at Guardians MH, and I am a crisis counselor with Crisis Text Line and an advocate for mental health.
And last, we've got Hannah from Popcorn Psychology.
Hi. Yes, I am a marriage and family therapist in the city of Chicago. I've been in the field for about 5 years. I'm currently in private practice.
Excellent. Welcome. So thank you, everybody, for coming together and once again answering the clarion call of the Mental Health Avengers. Unfortunately, last time, for those of you who caught our last episode, we had a few more folks. Unfortunately, due to the bug being this time of year and just scheduling things, our friends over at PopPsych 101, as well as Freudian Sips, could not join us for this. So this is going to be a little bit of an abbreviated episode. I mentioned before we got rolling that this is going to be the Infinity War of the Mental Health Avengers, in that we're only dealing with about half of our usual folks. The other half have been unfortunately snapped. But much... we will find a way to bring everyone back with the Infinity Gauntlet of mental health for the next go round. And thankfully, it won't cost me an arm.
All right.
So the topic this go round is access. So we're calling this Age of Access, as it were. And I know we discussed briefly during our last go round and in the thread talking about trying to come up with topics, we found that I think before we can even really get into some of the rest of the discussions around mental health, we have to discuss access first, because what kind of psychiatrist or what kind of therapist you have, what kind of mental health professional you're seeing, what kind of help you're receiving, all of that hinges upon your ability to get the help in the first place. And if you can't properly access the correct resources that you need, everything else is moot. And so I think discussing access is definitely a very important thing. And so I know I'll talk first, and then obviously we'll open up the floor. But and I've spoken about this on our show on Capes on the Couch as well. I was and still am looking for a mental health professional. I'm looking for a therapist. I have contacted a few that I found online. And unfortunately, my problem with access is not due to insurance or desire or even availability. It's really just no one's getting back to me. I've contacted at least 3 therapists, all of whom have posted online in some fashion or other that they are accepting new clients. And yet no one has emailed me back. No one has called me back. And I guess I'm grateful in the sense that I'm still opting to do this, and I'm still continuing to search, but it is very discouraging. And I would presume, and I'm going to throw this out there, I guess it's just a first question to the professionals here. What kind of impact does that rejection, and I'll put it like that, have on someone who is in a more desperate mindset, someone who is not in the correct headspace to have the resiliency to say, okay, it's not me they're rejecting, it's just, they're not available or whatever, that someone in a desperate mindset could potentially view that as a personal rejection. What does that what does that mean? Or what are your thoughts on that?
Well, being in private practice, we're always almost looking for new clients when we do have spots open. Unfortunately, the spots are very limited, or even with most of the psychologists in town, everyone is fully booked months in advance. So a lot of people have that feeling of feeling rejected when they can't get access. Because in private practice, we do take certain insurances that does help offset some of the cost. And that's an issue we can get into all by itself. But in the public sector, it's even more difficult to go see someone just because of the resources are so limited, and they're just really taking the most severe cases. So a lot of people get really discouraged. Certainly for someone that suffers from severe depression, that it took all of their energy just to make that one phone call and to be said, oh, they could see you in a month, or they're not taking any new clients now, we can put you on a wait list. That hits them really hard. And to me, as a therapist, it pains me to have to say that I have to put people on a wait list because I don't have any room.
Yeah. As a person who used to be involved in private practice and now is a part of a hospital system, I definitely have experienced both sides of that. I'll say that my current struggle is the same as most patients and clients, because it's our responsibility to get that person their next level of care. We're seeing the sickest of the sick at the time. And once we have them at a point where they're ready to go home or ready to move forward, we are able to kind of provide shortcuts through outpatient clinics. But even then, we point out our goal is to get the next appointment before their 1 month supply of medication is finished. We want to make sure that they have some level of continuity, and we pull as many strings as we can and our direct contact with other providers, and it still can be weeks at a time. So I definitely share that pain right now. So it's not just the patient or the client that has this problem. It's I'm going to extrapolate this out to primary care as a whole, people that make those kinds of referrals from their own doctor's offices that are constantly trying to find access for people. So from that standpoint, at least if it's coming from another professional, then the person can recognize we're in this together. We're still going to try. We're still going to do whatever contacts we can, but it's not going to be fixed overnight. And sometimes just having that type of feedback can, help that person remain motivated for their own health and their own treatment.
True.
So I think one of the things that is a rule or a law of some kind, that if somebody is has been hospitalized, that they have to have an appointment with an outpatient therapist like before their discharge. I know, and I don't know if it's the same as it is with you, where it's like essentially they have to at least attempt or make sure you have a phone number or whatever. Mm-hmm. And it's really, there's just not enough of us. There's not enough providers, and not enough of us take all of the insurances, which, is a whole other thing. But like so part of being at my private practice is that I have to have a Psych Today profile. And so I get people asking me all the time, and I'm currently, I see 35 clients a week right now, which is a lot, kind of, actually. And I still get emails from people on Psych Today asking, or clients that I see asking me if I have any openings for a friend, or do I know of places that take Medicaid for people who want to see, therapists who take Medicaid. So it is really, though, for you, Anthony, that is really unfortunate, because when I get emails from people, I at least respond back and say, hey, I'm really sorry, I don't have any openings, and then say, based on what you asked me about, and I usually send them 3 or 4 other options with phone numbers.
Yeah, and it's funny you mentioned psych today because that's where I found the number of therapists, and one of them did get back to me, and he said, I do have some availability because I had said in the email that I'm looking for a therapist, and before I book a formal session, I wanted to just talk for like 10 minutes just to see if we'd be a good fit. And the one of them did get back to me and say, yeah, call me on this day, or email me your questions, whatever, and we'll discuss this beforehand. And I texted and I called and I emailed and they ghosted me. And as I said, that, from my perspective, and I'm not saying this in like a braggadocious sense, but I'm grateful that I have the resiliency to not take that personally and to not say that it wasn't about me, that they were busy or whatever, but that someone, as I said, in a different headspace may have taken that much more personally, someone in much more dire straits. And that's the part that concerns me, is that, I don't know how many of those people have reached out, as Dr. Goku said, that it took everything they had just to make that call, and to then not hear anything back, that can really be a major blow to their psyche.
Yeah, absolutely. And I've experienced that personally. The first time I made a call to a therapist, I did it through a employee assistance program with the job that I had, which I was lucky enough to have a job that had an EAP. And like the part of their job was to call with me. So like we called the first place and they didn't even answer, and you couldn't leave a message. And so luckily we tried to call a couple more, and then that's how I got my first therapist. But like that's a lot of access that I had, and also I had insurance. Now one of my sisters, I would say struggles with a more severe depression, and it took her 6 months, because every time it happened, it took her a month to get up because it's a lot. It's a lot when you call, and if somebody's not nice, or if they or tell you, we don't have any openings, or if they just straight up don't respond, like even just getting a no, we're full, can set somebody back. Like it could take them up to a month to call someone. So part of what I like about the practice that I'm at, that I'm lucky to be at, is that we just keep hiring therapists. Like if everybody's booked, she just keeps hiring people. Like we have, so that we almost always have some openings. But we have I think there's 26 or 27 therapists and we have a psychiatrist now, which is amazing, because a lot of private practices don't have the luck of having both therapists and a psychiatrist somewhere. So I feel like we're doing a good job at that. And I used to work at a private practice. When I worked at the place that me, Ben, and Brittany all worked at together, we took Medicaid. And so that was really nice, because it really felt like we could help people who needed it. And also because we all had that experience too. I think that was really helpful. But I stopped working there, and because I don't work there anymore, I no longer can do Medicaid. And so what I tell people when they have a hard time is I talk to them about asking for a sliding fee scale, and seeing if there is I talk to them about if there's a counseling program at a college that's by you. Like they should have a clinic that is free. So sometimes I can offer those, but it's really hard, because it's set up in a very unfair way, for sure, for everybody. Like I always feel bad when I have to turn someone down. And I always try to be really like, I'm so glad you reached out. I try to be, but like, it still is really hard to say I just don't have any more room.
Mm-hmm.
I'm sorry, like, especially with that, it's great that your private practice has the ability to keep hiring more people to support, the huge number of persons coming in to receive, to talk to somebody, to receive help. But what do you think the what's the word I'm looking for? I guess I'm trying to formulate a high burnout rate with the providers if you didn't have the ability to bring more therapists on.
Ooh.
Do you think that's more of a thing that is seen today? Because there's such a high number of people seeking help, and it seems like a lot of practices are just overwhelmed with clients that burnout for the providers and long wait times for treatment is more of a thing today than it was in the last 5 years.
Well, I can jump back in with that one. My system is actively looking for psychiatrists, nurse practitioners, therapists, social workers, everything under the sun on an ongoing basis, because although it's clear that everyone that works within our system is highly dedicated, I'm saying this firsthand too, we all feel the strain of knowing that every person that comes through, this may have been the first time they're coming through, this may be the 50th time that they're coming through. Since I'm working on more of the acute care side of things, we get the feedback that you're our last hope. In other words, they've gone through the channels that Anthony explained, that he's gone through, and they didn't hear back, or they had someone previously and they no longer take their insurance or whatever it is. So now they're saying, we didn't want to come through this way, but we have to. And so we're in the unique situation where there's something called EMTALA in the United States. And basically what that means is if you show up in an emergency room, you cannot be turned away for treatment regardless of the ability to pay. And so all of us know we are going to be seeing that person. We're going to be managing their situation, whatever needs to be done in that moment. But the idea that we have to do that nonstop, and then if they're in the hospital, that we're continuing to do that, and we just had someone, for example, leave for private practice or leave for a different area or whatever the case may be, we don't have someone lined up immediately to take that spot. So then it becomes a situation where we're literally just taking on the burden of another doctor or another therapist all in the moment. It's not as if we say like, oh, well, we can ration it out or whatever. We can't do that. And so from that standpoint, all we're doing now is almost like on a day-to-day triage, not just for the patients or the clients, but for ourselves. Okay, who's the one that's going to have like double the load today? Who's the one that needs their own time down and an unexpected, mental health day? Not even using that in the pejorative sense, just the idea we're all trying to ration this out. And I noticed I had to be careful of this myself. I'm not saying this as a badge of honor. I'm saying this as just the fact. I worked 39 of the previous 40 days during the holiday break. And I did that just to make sure that everybody else that needed time with their families was able to get it. And so from that standpoint, I realized, because I had never done that in my life before, and hopefully I won't have to do it again, wow, we're a fragile group. We need to take care of ourselves just as much as any of our clients or patients do. So this access thing really does lead to, I think, an increase in burnout on both sides.
Yeah, I would agree with that.
Yeah, I think that's accurate. And I think, yeah, I think it's such a tricky, messy thing that shouldn't be that tricky or that messy, but just based on the way that the system is kind of set up. And also knowing that, and the other part of this too is like when I worked at the practice where we took Medicaid before, it was also the difference of having a client who is much closer to crisis than anyone else. And so then it's also, you also want to be careful, and you don't want to take too many people that are on Medicaid, because sometimes it can be really intense. And that also feels shitty too, because it's like, I want to help. I want to be able to help as many people, but also people who are willing and really need it. But part of what we did, part of the job that we all no longer do anymore was we helped connect people who had Medicaid to mental health professionals. And the amount of times that we were making phone calls to other therapists and psychiatrists, and people were getting appointments, like 6 months down the line. And half the time, literally more than half the time, I was saying to them, hey, well, here's the thing. If we can't get you in to see a psych provider before your meds are up, go to the ER. Like, I know you don't want to do that. And part of the whole reason why we had jobs was because we were supposed to help decrease the amount of times that people go to the ER, because they really need, they don't need emergency care as much as they need the outpatient part when they get out. And I ended up, I would say more than half the time, I would end up saying, I'm so sorry. I've called every day for 2 weeks. I can't even talk to somebody. Go to the ER and I will continue to look. And so it's heartbreaking, I think. And also the idea that a psychiatrist would be booked out for 6 months. Like, I can't imagine, what that's like for them either.
Yeah, that definitely sounds, just any job in general, having your schedule blocked out for the next 6 months to me is just a giant, I don't want to think about that.
Well, on one hand, yes, you're absolutely right. And I think within the field, we recognize this, but I'm also going to kind of look at this from a layperson's standpoint outside of mental health or outside even healthcare in general. If you had your own private business and someone said, hey, you have customers lined up for the next 6 months, most people would say, oh my goodness, my business is booming. We're doing fantastic. This is amazing. And don't get me wrong, it is a way to make a living. It's just that many times that's the only aspect that people come from. And so hearing that type of thing, on one hand, you almost say like, oh, well, then this person is in high demand. But at the same time, from the healthcare standpoint, we all know that means the opposite. It's more like, wow, this is the only show in town and we need to do everything we can. And therefore we're really pushing our limits. So that's something where I think there can be a bit of a gap there between public perception and what we're actually experiencing.
Yeah, definitely. I guess then the next thing, and I know we referenced it a couple times, and I don't think we continue to have this conversation without talking about it. It's the elephant in the room, and that is insurance, and the many problems that patients and clients experience due to insurance in this country. I'll speak, in the United States, and I know Dr. Goku had to step out momentarily. When he comes back, I want to get his take on the Canadian healthcare system. But just the idea that a healthcare insurance company is going to dictate how much care you can receive, what kind of care you can receive, how much medication, and so on and so forth. And the fact that those decisions are many times made by an insurance company and not the mental health professional and the provider itself, I think is troublesome. And so again, I'll throw it to the professionals in the room, especially, I know Doc, you said you've worked on both the ER side and the private practice side, and I know Hannah as well has worked in a number of different offices and such. How does insurance impact your ability to see clients? And what problems does that create?
Oh boy.
Yeah, all of them. I mean,
yeah.
I know that's the big question. That is the big one. But
you start. Go ahead.
Okay.
I'm only putting it that way because I don't know how to
bite
it down into smaller.
It totally makes sense, Anthony.
That's a great lead in. You know what? Then I'm gonna attack the part that frustrates me the most on a daily basis, because I know that this is the way insurance companies view me and my field. So as the pill pushers and the general pharmaceutical mill that psychiatrists are, it is our job and obligation to make sure that we provide the cheapest possible care with the fewest amount of prescription medications that will not bankrupt the insurance company. That is the most cold-hearted way I could say that. Yep. I recognize that that's okay. There's some nuance there. I recognize it. What they want us to do in general is use medications that are well studied, that are considered first line treatments before we do anything that's too out there, too experimental, et cetera, et cetera. And there's a basic level of protection for the patient when it comes to that. That's fine. However, I will say that the process of getting medications approved, even medications that are well studied and heavily prescribed and used for obvious clinical reasons, can be quite arduous. In other words, let's go with ideal world. Let's say I have a patient that I saw for a 30-minute med checkup, which, by the way, most insurance companies will say is too long. Then I prescribe I'll just go generic antidepressant medication. I'm not even going to give a name. And the person goes to their pharmacy, they pick up or think they're picking up the medication. The pharmacist then says, you need prior authorization. In other words, I need to call the insurance company and get that medication approved. This is after the session, mind you, not at the same time. So this is more time taken away from other patients that I have to verify that this is indeed the medication that I want that patient to get. And then I have to justify to the insurance company itself, either through another, and I will say this, it can be another psychiatrist, another doctor. Sometimes it's a representative, not a doctor. But in any case, explain my reasoning as to why I'm giving that medication, even though I just spent a half hour with that patient explaining why I would be giving that medication. So a person that's not even in the room, that does not know the situation, does not even know that patient, I have to justify myself to, which can be not just emotionally frustrating, but it takes up extra time away from other patients. And that's the baseline that we are dealing with when it comes to insurance on the medication side. And that's just that one component. So you can imagine the frustration from a patient who now was told that they would be receiving something that may be a tool to help them. And they have to wait for my approval, which if it does not happen that day, will happen some other time that they don't know about. And then eventually be able to start with medications that do take time to actually take an effect, well above and beyond anything that they originally signed up for. So we wonder why patients sometimes are not compliant with medication management. That's a big reason why, regardless of any poor bedside manner or overbooking or any of the other things that happen on a daily basis. So that's my rant about my most frustrating part with the insurance system that I think is a big barrier to care.
Yeah, and that definitely is very, very true. And it's so upsetting in terms of I was often on the other side calling. So I was one of the people who was calling you and saying, hey, these, I almost just swore, but I caught myself, that these people, that I have to call, and then I'm calling the insurance company and saying, hey, we need this medication. Like, I'm going to send them to the ER. So do you guys want to pay for a hospital stay? Because that's going to cost a lot more money than just giving this person the 30 days worth of medication that they need. It's just the way that it's just such a mess in terms of insurance covering it, in terms of because I think people also, the way that insurance works and the way that it essentially is, has the final say in everything. And there's not anything I can do about it. And like we accepted HMO, which means people can only pick from a certain provider, right? A certain set of providers. Their psychiatry department I had somebody who could get an appointment in the end of February that called this week, or with a psychiatrist that I know is not good and is trash, and I wish they didn't work there. Of course they have an opening. Or take one of the names that I gave them, and they won't see them until May.
Right.
And it's like, and like you said, and so what I do when I talk to clients who are really ambivalent about taking medication, I say, well, here's the thing, and that's totally fine. Like, you're totally allowed to make that decision.
Mm-hmm.
But if you're even thinking about it, it's going to take you a month to get an appointment, and it's going to take 4 to 6 weeks after that for anything to work if we're talking about an antidepressant. So you're looking at not having any relief possibly for 3.5 months. So and people have no idea. Like, when I say that to people, like, oh, it takes that long. And I'm like, yes, it takes that long. And these are people who have insurance. These are people who have, when I was fighting for people for Medicaid, there's so many things that Medicaid won't do that doesn't even make sense on the bottom line. Like, even if they were only looking at the money, it doesn't even make sense.
Right.
And it's infuriating. And especially being somebody who's in the field, it's something that I could never go back to working a job like that, because it feels like a really crappy thing to say, because I have access and I have my own therapist and I have my own psychiatrist because I have health insurance. And so for me but it's like the system is so broken in so many ways that just sucked my soul out. I mean, it was awful.
I hear you. And I could tell you that the way the system is set up, there's basically two extremes that I don't want to say they don't get fast tracked. I want to say that you have the opportunity for more flexibility, ironically, and it's not the mid-level insurance, middle class thing that we think about. It's either you have so much incredible money that you can go to a concierge practice that actually dotes things out months at a time, and therefore you can get the type of one-on-one treatment that you would classically think of, like you think Manhattan, classic couch or whatever that we've said in the past, that sort of thing. On the other hand, if you have absolutely, and this is not a way to cheat the system, to everyone listening, that's not what I'm getting at. If you have absolutely nothing, I'm talking not even Medicare, Medicaid, you are totally indigent, have nothing to offer. You go to the emergency room, you're going to definitely be seen. If you do require hospitalization, you will definitely be hospitalized. It's the hospital's obligation then to connect you with outpatient treatment, regardless of ability to pay. And all of that will be under charity care. The odds that you are actually going to pay anything out, they may send you to collections, they may do other things to try and get that bill paid. But if you have no money, you can't, squeeze blood from a stone. So in that sense, you will get some sort of treatment. Is it the type that I would ideally want? No. But the fact that you have basically the extreme ends that will end up with more than likely the quicker access to care with something that at least resembles what we would think of as mental health is fascinating to me, because everything else becomes an ultimate middleman arrangement. And the current process for it takes such an incredible amount of auxiliary staff just to wade through. I mean, you guys don't need to know about this, but the types of billing codes that we have to use and justification in our documentation and everything else on a regular basis, all before we even get to the idea of what are we actually doing for the patient, creates the type of burden that adds hours to every day. So from that standpoint, that takes away from time that we could be seeing patients on a regular basis. So if you want to talk about another barrier to treatment, it's the fact that when you have that much paperwork getting in the way, it limits what else we can do. You can only do one thing at a time. So that's just a little extra spin on it. And obviously it's clear that we can go on about this for hours. So I think I'll stop there.
Yeah, I was going to.
It's a little different.
I was going to throw it over to
Canada.
Goku. I wanted to get his take on it.
Yeah.
Because our healthcare system is a little bit different, but due to limitations in our healthcare system, psychological or psychiatric services aren't always covered. So if you're in the hospital setting, it's covered. Inpatient care at the hospital, everything's covered. You go in, you need treatment, they will provide that treatment for you. When you get out of the hospital, there are two real options. So you can go outpatient care through community mental health. That is completely paid for, but unfortunately the wait lists are rather long due to lack of funding or lack of staff. And then there's private practice that you fall into either paying out of pocket or having an insurance provider cover or offset some of the cost. And I know there's a lot of programs for a lot of different people. That's why I have a lot of variety, different types of insurance providers that we take most of every single one, but they typically pay around 80%. So it's not too bad for a lot of the clients. And then there are certain providers like, I know I do a lot of work with workman's compensation, so WorkSafe. And they tend to cover 100% if it's an injury that was suffered on the job.
Interesting.
Really?
Mm-hmm. But that's injury on the job relating to psychological difficulties. So a lot of the people I see with WorkSafe are suffering from complex post-traumatic stress due to the nature of the work that they worked in. So I have a nurse that's been that has complex post-traumatic stress that she's been working there for 19 years. I have correctional officers that have seen things that most people don't. And due to the nature of the work, the condition, them being placed off work, their workman compensation does provide for their treatment.
That's kind of...
It's interesting to get that different take on it. I'm sorry, you were saying.
Unfortunately, most insurance providers don't cover a lot. And that's the real stickling point. It covers about 3 sessions.
Oh, boy.
Oh, my goodness.
That's just beginning. That's you say your name.
Yeah.
If you have a good program, some people offer quite a lot, but it's based on how much they allot per year. And a lot of them are $300-$400 per year in psychological services.
Wow.
Yeah, that's a big thing down here. Like even with my day job with our insurance, and it's great to see that a lot of these larger companies are incorporating mental health care into their insurance for their employees. It's just so bare bones that you barely get any support from it. Like Dr. Goku was saying, 3 sessions, that's barely even starting any sort of development of a relationship between you and your doctor. I mean,
you're just starting to get comfortable.
Yeah, so it's great to see that a lot of these companies are making strides to incorporate it into the insurance and coverage, but it's just so bare bones it almost does nothing, to use it, which is sad.
Unfortunately, a lot of the bigger covering insurance providers like the WorkSafes, they require so much paperwork that most therapists don't want to take those clients because they don't have the time, or it's the amount of work that is required for one client is just astronomical that you could be seeing other clients.
Yeah, absolutely. And I think that's part of another part of things that I don't think people quite understand in terms of being somebody who takes Medicaid here. Their paperwork is a nightmare. I mean, and if the note isn't exactly right, you're not going to get reimbursed anyway. And also it takes anywhere from 3 to 6 months. And that's only if you're paying attention, because a lot of times they just won't pay you at all. And you get maybe like $40 for a session, which, is fine. But the idea that we can take all of the insurances, it just doesn't work that way, because in order to maintain the kind of paperwork you have to maintain and the paper trail you have to maintain to accept Medicaid is outrageous. So it also limits, we're also limited because, again, that same idea that we need to have time to actually see clients. So I can't spend half of my day making phone calls and getting prior authorizations for 2 more sessions. I mean, luckily at the job I have now, most of the people that I see, like I have to authorize every 10 sessions, but they're almost always authorized. Like I very rarely get any pushback, but it's still an extra thing I have to do for at least half of my clients.
Right. I can say that there's been some improvement when it comes to, at least in my state, in New Jersey, the authorization for hospital stays. It used to be that the default was, we're not going to accept this unless you meet a certain threshold. Now it's, okay, we trust you as the clinicians making the decision that the person requires hospitalization, but on the back end, you better prove it. And if you don't, they will actually retroactively say that the entire hospital stay is not covered. So we have to be very careful to, there's no other way to say this, we have to make sure that the person sounds ill on paper. In other words,
absolutely.
It's an interesting dynamic though, because on a day-to-day basis, I could say, hey, I can see you're improving. But in my note, I have to indicate patient still appears to present some sort of danger to self due to depression and suicidality or whatever.
Absolutely.
And then because now I have to review a lot of other doctors' charts too, I see this as well. I thought it was just me, but it's not. Where magically on the day of discharge, it's like, okay, everything's okay, you're good to go. And it gives a very strange narrative because it's basically sick, totally well. Like, no. That's not how any of
that's how it works.
Yeah. Right.
Yeah.
But unfortunately, insurance companies kind of tie our hands because if we don't, and I'm saying this with firsthand knowledge, if we don't word it that way, they won't cover the stay.
Oh, yeah.
You know, it's fascinating that we have to jump through those types of hoops.
One thing I've seen lately, because I've been hearing through the grapevines of other providers working with certain insurance companies, that the insurance companies are pushing for the therapist to clear the person to go back to work.
Mm.
And then their work saying, oh, you don't need to listen to your therapist or your doctor. They want to keep you off work longer than is required.
Madness.
Just because they don't want to pay for it.
Wow.
That's a
Which just
nightmare.
irks me to my very core.
Right.
Because they finally got access.
Yeah.
And then they're trying to say, you got enough after 2 months, go back to work.
Yeah.
And I can't imagine only being able to see people for 3 sessions. Like, I think, like, while that's awful for the client for sure and completely unfair, I think I would lose my mind.
Mm-hmm.
I think I would be like, I can't, it would feel so hopeless in terms of me being able to help people. And I mean, I would do it, don't get me wrong, for sure. But it would be, being in that setting and being like, man, like this person probably could be seen twice a week. Like, it just, it feels terrible. And it's, I can't imagine. And I know one of the biggest healthcare companies in the U.S. is United Healthcare. And they only allow, and they have lots of rules about their health, mental health coverage. And some people, I think it's like maybe 20 sessions in a year.
Yep.
People are allowed. Like,
that's almost every 2 weeks.
Yeah, but even still, that's at least far better than 3 sessions.
3, for sure. Yeah, no, 3 is definitely worse.
Yeah, at least 20 sessions, you have a good chance at
it is
setting them up for success.
Yeah, the 3 session is basically when they have like the bare bones, the cheapest level of insurance you could get, which is a lot of what people get. Through some of their work, they can get like 5 to 6, depending on what the plan is. and some people can go to like being covered for almost the entire year. I had one that I could see weekly for a year, and her insurance paid, was it 90% of it?
Okay, that's really good. Yeah.
Yeah. It is.
So it's depending on the company you work for, unfortunately.
Yeah.
So we've talked about, I guess we just talked insurance. We talked about the availability of mental health professionals to see patients, clients. What are some of the other major impediments to access that you've encountered in your professional experience? What are some of the problems that people have in getting the help? And as I said at the top of the show, we're going to discuss solutions the next time. Hopefully we get the rest of the Avengers around so we can all tackle this problem together. But at the very least, identifying what some of those other problems are, aside from insurance and aside from, mental health professionals just, I guess, being overworked or understaffed and not having the time to call everybody back. What are some of the other issues?
Yeah. Infrastructure as a whole. I mean, I'm going to try and represent people that aren't in the room. And what I mean by that is Anthony and I are located in one of the most densely populated parts of the United States. So it doesn't necessarily apply directly to us, but I know in a lot of middle America, I know in a lot of areas that are rural, it's purely there isn't even an infrastructure for mental health care. You have people that are literally just that one person for that area. Either they could see you or they can't. And if they can't, then you go to the emergency room. And if you can't make it to the emergency room, then I'm cleaning this up, then tough luck.
Yeah.
Well, just an example, I have a story of what one of my clients told me. She worked in Nunavut, which is a very remote place in Canada. And she was part of the second largest village in Nunavut. And they would, on occasion, have a mental health nurse, no psychiatrist, no psychologist, no social worker, no nothing. And if someone was in critical condition of either trying to commit suicide, they had nowhere to put them. So they took them to the local police station and put them in the drunk tank.
Oh, boy. Oh, because that's therapeutic.
Yeah. Let's lock them up.
Yeah. Not that they wanted to lock them up. It's because they
no,
had nowhere to
of course.
Right.
Yeah, no, absolutely. Because they don't have the proper...
The infrastructure.
Well, the infrastructure, yeah. Absolutely. Yeah, it's so funny that you brought that up, Doc. I was going to talk more about, because, we're in Chicago. So even though I definitely work with some people who location is a problem, but I would say thinking more of at home in Michigan, where, you have to drive at least maybe 40 minutes to an hour to see somebody, if you even have the capability to do that. And yeah, I think the rural communities are the ones that are lacking in the biggest way in terms of mental health and substance abuse treatment. I think that those, it's just it's so few and far between that I can't imagine how hopeless that would feel.
Well, I have some clients that drive about in between an hour to 2 hours to come see me. And I'm in the largest city in my province.
Wow.
Although we're not that big, we're 140 some thousand people, so we're big-ish. But some people drive an hour or so to come see me at my office, because back where they live, they have one person.
Yeah.
Or none.
Right. And that's the thing. We're talking, person, not even
exactly.
System.
No, one person.
Right.
That's rough. And again, I mean, and that's why I posed the question, because I know everybody has different experiences. I mean, we live in a very suburban area. We're in New Jersey. We're right between New York and Philly. So there's, and the section of New Jersey that we're in is very suburban. But I mean, I could go to parts of New Jersey where you would have to drive a considerable distance to find, people. And that's putting it politely. But it boggles my mind, I guess. So is that suburban privilege? I don't know. Is that a thing?
Well, I mean, there's a part to that, but to get back what was briefly touched on, since we're going to ask like what other potential barriers there are, I would say even within our own field, depending on where we're practicing or exposed to, is the substance component. Because I'm not going to speak for anyone else. I'll speak for my experience. Getting other healthcare providers to acknowledge the fact that is a huge part of maintaining a person's health, regardless of any other mental health condition, and just throwing everything towards whoever it is, be it a psychiatrist, therapist, psychologist, social worker, and say, here, you fix all of it. I remember this vividly when I was doing outpatient. I had a gentleman that was literally shaking in front of me, and I just had to call 911. I said, "This is not the area for you. You do need the hospital. You're going through withdrawal right now." And they said, well, whenever I told my doctor, he would give me some. I'm going to actually say a name of a medication. He gave me chloridase epoxide, or Librium in America, and he said, "Don't worry, you'll be okay." And I'm like, that's that's a little. Yeah.
Oh my gosh.
So what I'm getting at here is,
I'm so freaked out.
I'm sure you are.
I'm so freaked out. Okay, go ahead.
Well,
sorry.
My point of this though is to say that yes, we can talk about the barriers in terms of lay people, but even within healthcare itself, sometimes our own kin, our own people don't recognize what's going on often. And I do think that there is more of an onus on us to properly educate. I remember right after that happened, we actually did have a continuing medical education that I led on alcohol withdrawal, just so that everybody got a better feel for what was really going on. But I do think that that's a part of it too, because I'll be honest, I can't remember exactly when the study came out, but the whole point was, in terms of suicide, the last healthcare provider that the person saw usually was their primary care physician.
Mm-hmm.
So from that standpoint, that tells you right then and there, that's the person that has the greatest potential impact on navigating these waters. And
absolutely,
I know
first line.
Yeah. And I know for a fact that many of them feel either overwhelmed or scared, or to be honest, there still is a stigma and they just don't want to be bothered. So from that standpoint, I do think that's another barrier.
Or a lot of them don't want to look at mental health because they're either uncomfortable or it's not their area of expertise.
Absolutely.
They're either going to overprescribe and not refer, or underprescribe, either refer or not refer at all.
Yep.
Yeah.
You were talking on stigma. One of the big things for me in my practice is still stigma, depending on the clientele that I work with. Certainly for correctional officers, the stigma is huge still. Some people that should have come to see me 10 years ago are just finally coming into my office.
Yeah, it's I would say even between the amount of people who come in and do the intake and will say something like, I've been thinking about coming for 2 or 3 years, and it's just, the way that it's just the way that it's set up, and the idea that anyone in the field, in terms of helping people be healthy to whatever capacity, the idea that people don't want to look at someone's entire health is just obnoxious. And when I I try to, when I talk to people about, about all the different things they're on, or even, I was educating, and I was, so I have a couple that I work with, and both trying to manage their substance use. Now, I'm not a substance use therapist, but you have to learn how to work with people, because otherwise you just can't be in the field, really. If you're going to push off everybody that struggles with the substance abuse issue, you're kind of screwed. And this is somebody who, again, is going to their primary care doctor. Primary care doctor is prescribing Xanax and, I can't remember the other medication, and knows that the client struggles with substance use. But I, who is not a medical provider, was the one who said, hey, cool side note, you keep doing what you're doing, there's a chance that you might die. That combination of those two things is not okay. I was like, if you're going to do withdrawal, you're going to need to go to detox. Like and the couple, they were stunned. They're like, what do you mean nobody's ever said that before? I was like, yeah. And I'm like, I shouldn't be saying that. Like, they're here for help with their couple relationship. But I'm, it's just, and the fact that I think it's just so upsetting to be in a field where everybody doesn't feel that way. Like, are you kidding me? Like, it's so, I know that we have a lot of work to do, and I know that it's, it can be hard or whatever, but it can take me 2 seconds to send an email or to say, hey, it sounds like you should go to the doctor, or like whatever. And just the general access to education about mental health in and of itself is another big part of all of this, that also I think is also linked to people having general medical education as well.
Excellent points. Yeah. So I think we've identified a good number of problems, and we could continue to go on here for hours and hours on end. But
so many stories.
Exactly. Yeah.
Many terrible.
I'm sure the professionals here could talk about stories on end, and that may be a separate episode. But I think we'll cap it here, and no pun intended, I swear. And we will save the solutions for the end game, so to speak, of this when we get the rest of the Mental Health Avengers back, and I will be sending you all the notification for the calendar invite, so we can try and schedule that for the next go round. But as always, this is an absolute pleasure and delight spending time chatting with you all here. So why don't we go around again and just remind everybody who you are and where they can find you, your shows, your podcasts, your communities, what have you. We'll go, I guess, in reverse. So Hannah, why don't you start?
Okay, so I'm Hannah. I would do a podcast called Popcorn Psychology, where we have 3 different therapists who talk about, we take movies and talk about mental health, and in terms of treatment, different things that we would do, and just kind of try to help decrease mental health stigma. You can find us on any podcast platform. We're at Facebook, Popcorn Psychology. We're on Instagram just with Popcorn Psychology. And then on Twitter, we're popcorn_psych. And then you can email us too with any questions or ideas for episodes at popcornpsychology@gmail.com.
And as always, it's a pleasure talking with you. And hopefully we can do another crossover with Capes and Popcorn Psych. I don't know what your calendar is for your upcoming 2020 schedule, but, Doc and I are always available to chat with you guys. It's always a great time. Joe and Dr. Goku, tell us a little bit about Guardians MH.
Well, I'm Dr. Goku. I'm the clinical director with Guardians MH. We should be starting our podcast back up for the 2020 year. We have a good and interesting guest coming up this week. The Gamer Doc is coming on.
Yes.
So she's a physician and leaning into esports. So that's going to be interesting to speak with her. We're going to PAX East this year. So our first time at PAX East. If anyone's there, come see us at our booth. And we have our Discord or Twitter, where we have a whole bunch of people that help on peer support. We have some mental health professionals and resources there as well.
Excellent. Joe?
Well, Dr. Goku nailed it right there. The only thing I can add is you can find us on Twitter. Links to our website, guardiansmh.org, can be found on our Twitter account, as well as pinned at the top, a link to our Discord. It's open all the time. It's a very safe place and open to everyone and anyone. And like Dr. Goku said, we're hosting a booth at PAX East this year in the Diversity Lounge. We are one of 21 organizations and other nonprofits that will be hosting a booth there, and we're at booth 9. So if you want to come by, it's February 27th through March 1st, and we'll have some great resources to hand out to everybody. Some little bit of swag's going to be there too. You never know. And,
I did see the swag. It looks pretty sweet. You want the swag?
You get a free one now. No, I'm kidding. And that's it. Pretty much. Dr. Goku nailed it right there. I mean, I think he's going to be closing the podcast from now on. He did such a good job. But yeah, we're going to be kicking it off this Thursday night with a live stream of it. So episode 1 of season 3, it's going to be kicking off. It's going to be exciting. And you can find that on iTunes and wherever you get your podcasts. Yeah,
we just did season 4. We just started off our season 4. So we are Capes on the Couch, Dr. Issues and I. And we are found, capesonthecouch.live is the website. You can find us on Facebook, Instagram, Twitter, at Capes on the Couch. You can email us, capesonthecouch@gmail.com. We do have the Patreon and a TeePublic page. And I think that's, that's just about gonna wrap it up for us on our end. So Doc, I know Doc has a Twitter account, which he's rarely on.
Yeah, I'll admit social media is not exactly my biggest friend right now. But no, I mean, honestly, at this point, I think Anthony said everything that needed to be said. Like I said, I'm still in the field, board certified psychiatrist in the state of New Jersey. It's amazing. I can't believe I actually have to say this out loud, because I've been told anytime I actually give my title, I have to say it full. Medical director and chair of medical staff for, I'm not going to give my hospital, but basically it's a freestanding inpatient psychiatric hospital with 100 beds. So, anybody that needs help in the state of New Jersey, they know our name. They know where to find us.
So that's going to do it for this first part of the second Mental Health Avengers. And when the next time we get together, we will be discussing the solutions to, or at least some proposed solutions to the problems of access. So thank you to Guardians, thank you to Popcorn Psych, and also make sure you check out our fellow Mental Health Avengers as well at Freudian Sips and Pop Psych 101. Those are the other Mental Health Avengers, and hopefully they'll be able to join us next time. So for everyone, I'm Anthony Sitko. Thank you so much for listening, and we will see you soon.
Bye.
Bye, everyone.
Bye. Thanks.
Bye, y'all.